In preparation for the implementation of the National Health Insurance, the National Department of Health, in partnership with the Department of Science and Technology and the Council for Scientific and Industrial Research, CSIR, began development of the Standard-Based Health Patient Registration System, HPRS. This large-scale initiative would require computerization and connectivity at all health facilities in the country. At the start of the African Health Interoperability Exchange Project in 2017, the HPRS was already in active national deployment.
The HPRS is primarily the authoritative source of patient identity and demographic information for the country. And this is intended for public and private sector health. In order to enable that functionality, it has a number of additional features that present itself in the front end to users. It's typically used by clerks in health facilities, and they will use it to register patients if they aren't there, or to retrieve their information if they do already exist in the system. It's used also to help locate patient folders, electronic or paper-based. It's used to schedule appointments in primary healthcare facilities. The other thing it does importantly also is that it manages and assigns to each patient a unique identifier called the HPRN, the Health Patient Record Number, and this serves as the National Health Unique Identifier.
The CSIR had dedicated a team of specialists with many years of experience in the development of interoperable data-intensive solutions for public sector service delivery, including healthcare. This team was assigned to the development and maintenance of the HPRS, as well as the interoperability components between the HPRS and other systems.
We built it from the ground up, from scratch, and we focus both on the front end in terms of the user interface and how the user experience will be, and also the back end and the integration engine that drives the use of the HPRS as the master patient index across the country. As I said, we built it from the ground up, so we didn't start with an existing product and customize it. We started with a clean slate and built it bespoke according to the requirements of the National Department of Health. The HPRS was built using almost completely open source technology. It's built as a Node.js web application using the Express web application framework on the server side and using backbone.js on the front end. The front end of the application is an HTML5 application with JavaScript and CSS. The front end should run in any browser, but it's tested for Chrome, modern Chrome browsers. The back end runs on a Linux server. It uses PostgreSQL as the database. We also use Redis to manage our session data. And we use a number of other open source tools and technologies for system management, for monitoring, et cetera, et cetera. Examples include the Salt Stack management software suite. We use the ELK stack, so that's Elasticsearch, Kibana, and Logstash, sorry, the other way, L before the K. The ELK stack we use for monitoring. We do also have some proprietary technology that is related to securing our data centers. So database activity monitoring software and intrusion detection software and the like.
The team at CSIR is continuing to work to enable interoperability between the HPRS and other health systems.
So the HPRS supports the current version of the Health Normative Standards Framework, notably the PDQ and PICS profiles, PIX and PDQ. So this enables any third-party system that is authorized to connect and that is compliant with those standards to be able to interoperate with the HPRS. We have a number of existing integrations, including with the National Health Laboratory Service and with the Western Cape's PMI, Patient Master Index, as well as a number of other third-party systems, such as those used by the city of Joburg, for instance, called Medimass. Also systems like Tier.net, Virtual Purple, EMR, and others, Meditech as well, I believe. And I think also the HMS2, which is a hospital management system developed by the Eastern Cape government. It comes down to having a single source of truth as it relates to patient demographic and identity information. So Other systems don't need to worry about who the patient is and what their demographic information is. They rely on the HPRS to provide accurate information for that. And the integration allows that sort of delegation of that concern, let's call it, to the HPRS. It also allows other systems to always be able to retrieve the most current and up-to-date information about a patient. And it enables the linkage of patient information across different care settings and across different care systems or healthcare systems, because they are essentially keyed using this unique identifier.
One of the goals of the AHIE project was to mature the HPRS further by enabling interoperability with the National Health Laboratory Service, or NHLS.
Every time a laboratory order is received, it's supposed to be affixed with a sticker containing a barcode of the HPRN. So that is scanned by the entry clerk. The patient's information is retrieved from the HPRS and updated in the NHLS systems. So this allows for more accurate identification of patients, and in particular the patients for whom tests have been ordered. And it also helps potentially prevent the incidence of duplicate testing, because one would be able to identify that this is indeed the same patient for which a duplicate test is being ordered.
In order to improve the accuracy of the data held in the HPRS database, it is necessary to cross-reference against other large databases containing population data, for example, the Home Affairs database.
In the case of the Department of Home Affairs, it is their mandate. They are the authority responsible for registering births and deaths, and vital registrations, as well as for maintaining this population of the South African population, both legal residents, citizens, and legal visitors. As a result, we are very eager to be able to reference the Home Affairs data whenever possible to improve the quality of our own data, and ultimately in the future, perhaps to enable a bidirectional flow of information. I think the Department of Health often see people more frequently than the Department of Home Affairs, and may, for instance, have more up-to-date contact information for people than Home Affairs would have. So the way we've approached this is along a number of tracks. Firstly, we are doing some basic verification of information we have in batch mode. So we have a process set up where we take a limited extract of the data we carry, we submit this to Home Affairs, and they give us back the data that they carry for those records, and we are then able to match and merge and update as appropriate. This is something that's done in batch. There are plans, and the work has actually been done to implement that as a live interface, sort of a more transactional, not a batch type of process. But that is unfortunately stalled, not for any technical reasons, just because of processes that take long, interdepartmental processes and agreements that sometimes take longer, and obviously a lot of things were thrown upside down with the lockdown that occurred and made certain processes in government, I think, slower. So that is the second mode of integration and verification against Home Affairs. And then the third is a variation on that live interface, which includes also the ability to verify biometric information. So it would allow us to verify fingerprints for patients, for instance. At this stage of the three, as I said, the first one is implemented and working. The second one is ready to be implemented, but not yet. And the third one has not yet been developed.
The team at CSIR has ensured that all measures are in place to ensure the security of the HPRS data and to protect the privacy of individuals.
The HPRS carries no clinical information, carries only personal and demographic information. It doesn't mean to say that we shouldn't care about privacy and confidentiality. That information is considered confidential also and should be protected. But it's not as sensitive perhaps as some, or perhaps considered slightly less sensitive than clinical information would be. But this is a sort of a macro level design principle as well. With the principle was to keep personal identity separate from clinical information completely, so that the two can only be linked indirectly, never directly. In the context of things like the Protection of Personal Information Act, that is obviously being implemented. There are a number of things we've put in place to safeguard the information. So these range from the traditional technical kind of controls we have, such as securing our data center, securing data in motion, data at rest, There's also an increasingly mature governance framework that we built around this project, particularly looking at issues such as policies around data use, particularly by third parties when it comes to sharing and making sure the correct agreements are in place. We've applied industry best practice wherever we can. So this relates to the way we've secured the data, the way we've secured the systems, the way we've secured the networks and the communications where possible. And increasingly also the non-technical aspects such as governance, data governance, and in particular the governance of interoperability as well. Governance of systems that are permitted to connect to the HPRS, for instance, and what they're allowed to do with the data that they get.
Work on the development of HPRS is ongoing, with several important features still to be added in preparation for the National Health Insurance.
What is envisaged is further implementation in hospitals, in secondary care facilities and tertiary care facilities, as well as the use of the HPRS as one of the foundational building blocks for the information systems required to operate the National Health Insurance. So in a sense, the future of the HPRS is along two tracks. The one is around implementation, and they're complementary. The one is around the implementation of the NHI and providing the necessary information backbone to be able to facilitate that. And the second one is to continue to facilitate interoperability of health information systems in the country by providing a single source of truth for patient identity information.
The African Health Information Exchange Project has provided a unique opportunity for collaboration within the consortium, with positive outcomes.
The biggest highlight was the bringing together of different parties to collaborate. I think on a pretty large and broad scale for the first time. The first time that I'm aware of in South Africa. It brought together the National Department of Health, representatives from academia, from research organizations, from NGOs, funders and donors. And I think at least it's the first time that I've been involved in such a collaborative project. And I think besides the technical outputs that were produced and some of the other successes, I think one of the great successes was the establishment of this network of experts around health informatics in the country.